Please join me in welcoming to the Distinctive Voices podium, Dr. Michael Yip.
Hi, everybody. I'm really happy to be here and be talking to such a distinguished crowd about what I've been really working on for about 20 years of my life, and that's really when I started when I was an undergraduate. And it's really this idea that robotics has a lot of value to the healthcare of our nation. And so today I want to talk to you about where we're going with robotics and healthcare, in particular surgery. And I want to start with this idea that surgery and healthcare, like many different areas in labor, is actually seeing quite a shortage of skilled workers. If you look at the healthcare industry right now, there's not only a huge shortfall of surgeons, but also a shortfall of nurse practitioners. And my sister is a registered nurse, and she tells me from her experiences just the enormous amount of burden that is put on the system, her colleagues, and also the healthcare staff that support each other. And one of the things that robotics brings to the table is exactly like labor, right? And in particular, physical labor. And the advantage of a robot is that it's never going to really get tired. It might run out of power and it needs some charging, but it's not going to get tired. It can run almost indefinitely. It has something also that's very unique in that it is very precise, to sub-millimeter accuracies if you need it to be, something that humans are just not very good at doing. The other thing that's really interesting in terms of a robotic system is that it has a scalability factor that is unusual and not found in nature. So this idea that if I teach one robot to do something and it's programmed in its software, I can basically download that knowledge into another robot and actually a fleet of robots, right? And this paradigm of person teaching a person, surgeon teaching a surgeon side by side, that growth is broken by this notion of an intelligent machine. And finally, one of the very interesting aspects of, again, machines and robots is that you can have programmed uniformity. So one of the things, when we think about going into a healthcare environment is a consideration of what is the quality of care I'm getting, right? Between doctor to doctor, healthcare team to healthcare team. And by being able to program the uniformity of behavior brings a lot of advantages. Now, unlike when we talk about this idea of robots that have the ability to kind of interact in the real world and have basically artificial intelligence built in, it's very different than the kind of artificial intelligence we talk about today, which is things that are built off of chatbots, right? And other models that can produce language and images and videos. Robots are harder in the sense that they have to interact with the physical environment, and they need to understand that the physical environment is really an uncertain and a dynamic place. Unlike language, which have a finite set of words and vocabulary, in physical spaces and robotics, we're dealing with continuous 3D space where in some cases, kilometers matter, but in other cases, millimeters will matter. And this huge dynamic range of state and action spaces becomes very hard to deal with. Another thing that robots have to deal with is the fact that we're constantly, when we interact with the world, we're constantly being constrained by the limits of the world itself, right? So interactions with delicate objects or complex objects that require stability bring in additional challenges. And finally, in many applications where we're concerned about, especially in the ones I'm interested in, robotic surgery, is that this notion of real-time, safety critical, zero error margin needs become quite important. And so when I think about where, and what I'd like to impress on, where we think about this idea, where we should go with this idea that we want to make robots more capable to help out in an operating room, I'd like to impress this idea that this embodied intelligence for a robot should include ideas of perception, modeling and simulation of the world. A term these days that are thrown around is world modeling. So really understanding how the world works. Planning in the world, understanding how everything I do has a sequence and steps and consequences. And then finally, the actual task of executing that objective. So those four kind of pillars is what my lab works on in San Diego. We're, again, situated on UCSD campus. And a lot of the work that we do is both on the theory and modeling, simulation, and algorithmic side, but we also build actually quite a lot of surgical robots as well. So what does a surgical robot look like? For those of you who are not familiar, this is a Da Vinci surgical robot. It's one of the many surgical robotic systems out there. It's been around actually for over 25 years. So this technology, this video is actually of a product that was released in 2004, I believe. Okay, this is the second version of the Da Vinci robot. So it's already an incredibly impressive mechanical system. You can see that it's being teleoperated using two fancy joysticks that are connected to the surgeon's hands. And the robot itself is mimicking those hands, but at a very scaled down workspace inside the body. And so this is where we were 20 years ago, right? If you look at it today, this is just a fraction of the robots that are out there, okay? When you go into a hospital today, if you are going in for certain procedures, like a prostatectomy, so removing part of the prostate for prostate cancer, or hysterectomies, right, removing ovaries for ovarian cancer, the likelihood of you getting a robotic procedure is higher than you getting a non-robotic procedure. Okay, so robotics is here, a lot of robots are here to stay, and this is just a snapshot of the many, many companies that are offering surgical robotic technologies. But remember, they're all currently being teleoperated, right? So they don't inherently have skill. They're tools for a surgeon. It makes the surgeon more precise and less tired, but it doesn't actually help us address the core issue that we have in healthcare today, which is limited access, lack of skilled labor. And if we look on the flip side for how robotics have been used in places like manufacturing, that's great. We have autonomous robots that are able to do a ton of mechanical and physical labor, but they're not necessarily skilled either, right? They're doing the same repetitive motions. They operate only in structured environments. They have extensive setup and human oversight, in spite of the fact that they do excel at speed, precision, and repeatability. And so, again, surgical autonomy, though, is not a new concept. More than 30 years ago, actually, was the first surgical robot that included some form of autonomy and basically voice commands saying, I'd like you to move the camera left or right, up or down, right? And that camera would basically move based on robot actions. And other research groups have shown really impressive things like autonomous suturing back even more than a decade ago. And so what we've been doing in my lab has been really trying to push this area forward and really looking at how we can handle more complex environments, things that are involving soft tissue cutting, suturing, deformation, and bleeding. For the most part, most of these videos are going to be of butcher shop meats that we're demonstrating on a lab bench. So generally speaking, no need to be too squeamish about this. video. Okay. So let's get started in terms of how we look at this. And first thing is that a robot is only as good as its perception. And really only recently, in the past few years, have we been able to come up with computer vision models that can look at images and videos and do really, really good segmentations of the scene, recognitions of objects in the scene, and tracking at a very fine granularity. And it's really important to have this very high capacity for perception, because perception, which is things like 3D reconstruction, localization tracking, and understanding like local context cues, they directly bridge over to world understanding, right? Things like geometry, physics, the notion of causality of these physical actions will lead to what downstream mechanical or physical consequence. Okay, so unfortunately, surgical robotics is the worst environment for physical AI. The next video is the only one that is actually of a surgical environment, just to give you a context. Okay, so in this video, we're looking at inside the body and a Da Vinci robot cutting, trying to get to a certain anatomy. And you'll see it has really very small field of view. It has almost no depth understanding. There's specular reflections of blood and smoke. You're always kind of blocking part of your scene with your instruments. Everything is deformable. Nothing can be like a physical anchor really effectively in space. And you also have issues that the common modality today is to use a ton of data and learn a machine learning model. And because of HIPAA, I wrote data issues, but I wouldn't say it's an issue. But because of HIPAA rules, we're not really like having a lot of access to a large data set to learn machine learning models off of. And yet we need robots to learn to understand the world to millimeter level accuracy. And so the way that my lab has actually gone about looking at this problem is to construct a vision system for a surgical robot, basically a surgical AI system, component by component. And that involves things like figuring out where your robot is in space relative to the tissue. We do a couple of ways. We have a couple of ways to do that, notably using an understanding of camera projection models and 3D models of our tools to basically do alignment in 3D space. But we also have the need for precision object localization. Let's say you're handling suture needles or you're interacting with tissues. You also need 3D deformation reconstruction. And so I talked about occlusion, and you're constantly moving your instruments over the scene and blocking your view. You need to be able to measure and track that deformation and keep track of that in kind of a panoramic fusion style. And so if you take these ideas one by one and you build engineering solutions around them, you basically can reconstruct a 3D understanding of the scene for the robot. And this is an example of a framework that we built a couple of years ago that takes the camera view of the robot, and it breaks down the different components of localizing the instruments on the bottom left, reconstructing the 3D deformation on the top right, and kind of understanding the scale of stress and interactions on the bottom right with the tissue. A lot of this is based off of this idea that was inspired from the computer graphics community, actually. This idea that deformable scenes can be broken down into sparse nodes, that as you shift those nodes around, it has a local behavior to move everything close to it with that node. And that's kind of like shown on the bottom right with in the computer graphics community, where they're showing that with a couple of key like points on the purple dots, you can make the whole body of a deformable object, in this case a giraffe, deform naturally. Okay, so we might be able to get the visual behavior of the scene to look accurately, but is that enough for a robot to really understand what it's interacting with? And do we need to have a better understanding of mechanics? And the way that we have approached this is, yes, I think that we do need a better understanding of mechanics, especially as we consider like cutting into tissue. And so this concept of digital twinning comes up. And so the digital twin is where you see something in the camera and you have a simulated twin of it in basically the robot's processing of the scene. And so this is an example of us using the camera view to get a 3D topology in the middle, and then converting that into actual real-time simulation. So kind of a neat, another kind of interesting aspect of this is that this 3D simulation is based off of a technique called position-based dynamics. Position-based dynamics was developed in the computer graphics community again as a way to simulate things like snow and fluids in Pixar films and Disney films. Okay, so we've been we've benefited a great deal from that community. And so this idea of going from vision to a simulation is what we call the real-to-sim pipeline. So you start with an image of a chicken breast, right, that we grab with a robot tool. We get an image of that, we convert it into a 3D estimated depth map, and we bring that into a simulation. And then we try to simulate it and see what happens, right? So when we do that simulation, right when we try to move the chicken breast with a real robot and we look at what the simulator tells us should happen, there's immediate mismatch because a single image is not enough to know the stiffness of the tissue, right? And so how do we get to the sense of what is the stiffness of the tissues that we're interacting with? And that's where we can bring in multiple consecutive images and interactions that will tell us more and more likely what is the mechanical parameters of that tissue that I'm interacting with. Things like stiffness and damping and viscoelasticity. And so this is an example of one of my students' work on playing around with a mechanics model where as you play around with the tissue, it gets better and better idea of the stiffness properties of the tissue, and therefore the prediction errors on the model that the robot is going to basically behave off of is going to be better and better. And therefore the robot will be more understanding of what it's interacting with and safer. So we can take this idea of looking at images and converting them into understanding of mechanics and deformation, not only for surfaces, but we can do it for things like rope, right? Rope in the body would be things like vessels that you're interacting with, as shown in the bottom left, as in a simulated vessel. But we also decided, well, the most extreme form of a deformable item is fluid, right? Fluid is basically inherently the most deformable thing that you can have. And so here's an example of going from single images, a sequence of images of there's chocolate milk being poured in, to measuring the flow rate of the chocolate milk in the pixels and estimating the fluid properties of the chocolate milk. So the simulator now understands the viscosity of the chocolate milk, okay? And it understands where that chocolate milk is gonna flow in the next couple of scenes. Now, why is this interesting to us? Is because when we abstract this, not from chocolate, not to like food, but to blood, right? We can now look at this scenario where we see blood pooling. Let's say a hemorrhage occurred, right? And as the blood pools, we're estimating the viscosity of that blood. And if you have a model of the mechanics of blood flow, you can not only predict where it might flow next, But you can close the loop using control theory to find the fastest way to suck up all that blood. Okay, so this is a way for us to basically find an optimal solution to suck up the blood and clear it out so that the hemorrhage can be attenuated. And finally, the final kind of point I want to bring on the perception side is that what about things like where are tissues connected? We can also understand by tugging on tissues slightly that tissues are connected in this region or another region. And we can estimate that both not only from a deterministic standpoint, but also from a standpoint of stochasticity. So we can get a semblance of uncertainty, and that will mean that if I'm more uncertain about where something is connected to, I won't pull as hard, and that gives me an idea of safety. And if we know where things are connected, that means we can know where to cut. And so this is the example of autonomous surgical assistance for dissection. And so this robot is autonomously moving in actually pulling back the tissue for another robot arm to come in and do some electrocautery-based dissection. And underneath the hood, though not shown here, is that it's actually mapped out the whole scene, the mechanics of that scene, the deformations of that scene. It's gone in and predicted what will happen if I pull in this direction, and it's verified this is like how far can I pull before I should stop and let the instrument cut. Okay. Just a couple of different other things to show is that we obviously also have to be able to pick out objects in the scene. This is an example of identifying suture needles in the scene, and this can lead, therefore, to our ability to kind of do repeated hands-offs of suture needles. One of the things for those who are not, or have never been trained in suturing is that there's actually an ideal place to grab a suture needle, an ideal orientation. And so we actually used several techniques to teach a robot where it is ideal to grab. And this is what you're seeing here. So it's using the vision system I demonstrated in the previous slide, but this vision system that I demonstrated in the previous slide. But then how it's learning to grab the needle in the right place is by using reinforcement learning, which is where you're presenting the scenario in a simulated game environment, and you're telling the robot, try and try again to get the high score of this game, which is actually the orientation that is ideal for grasping the needle. Okay. And then another thing that we've done is also suture thread estimation. So it's really hard to see in the images, which kind of indicate how difficult this can be, but there's a thin line on the left two images that show a suture thread through the scene, and an undergraduate student, a very talented undergraduate student of mine, went about trying to reconstruct the 3D shape of this thread based on geometric cues. And he incorporated this idea of understanding that in certain locations it's a little difficult to see, and so there's bounds on our ability to be certain of where the reconstruction is most accurate. And in the places where it's most accurate, that means that if I want to try to grab the suture needle there, I'm pretty sure I'm going to pick it up. Okay, so all of these tools, right? Vision models, adaptive physics models, and even control and planning tools, they are really a set of tools that are independent, and they could be shared together to create something that is autonomous. And so the idea is that by advancing these tools as techniques get better, we can improve their capabilities, improve the reliability of each of these tools, whether it's perception or control or modeling. And then by assembling these tools in different configurations, we can basically demonstrate new autonomous capability in new scenarios. And so one of the things we were interested in is this second question of like, well, what does assembly look like, right? And there's a way to assemble it where you just engineer the decision tree, like if you see this, do that, if you see that, do that. And sure, you can do that one at a time. And there's going to be a lot of decision trees you have to engineer. But there's also another approach where the approach is to basically take all of these tools and let the system kind of figure it out on its own how to match them and mix them together. And this idea, again, brings together the idea of reinforcement learning, which is you're in a simulator, you're giving an environment to a robot agent to kind of play around and see what happens when it does certain actions and it sees certain observations. And you give it a score, right? And it tries to win the game by maximizing this score to say, I want to get this task done. The score is really high when the task is done. So I'm going to keep playing and keep playing. I'm going to randomize what I do until I learn to perform this task really well and get the highest score. And so we take this idea, we combine it with these disparate knowledge models, and we can actually see an emergent behavior of basically a surgical robot learning new indications, new types of tasks, doing new types of tasks. So I think the thing that is unique about what we've done compared to a lot of people in the field is that when we look at the type of tasks we're doing, we really are being as heterogeneous as possible. So it's not always the robot should go in and do some action. Sometimes a robot just needs to look and track an object. And so one of the actions is just to track an object versus another type of action might be to try picking up the needle, try to re-grasp a needle, try to try to transfer objects between the hands. And so these are all kind of intermediate skills that are very heterogeneous, but when put into this reinforcement learning framework, they end up emerging with a policy that can achieve some pretty nice downstream tasks, like autonomous suturing. And so this is just a glimpse of our simulated environments that we let it play around in, where it trains itself to do certain subtasks. This is what it looks like when it's actually trying to do these subtasks in real life with our Da Vinci robot. And here it is where it's carrying out a whole sequence of these tasks in a sequential manner. So things like re-grasping needles, stopping and getting a 3D position of the needle, tracking the needle, doing the throw and threading it through, gripping onto the tissue so it doesn't slide on you. All right, so I will say that this work is basically, up until now, it's about 10 years of work in my research lab. Okay, so it's a lot of work and a lot of students, and it's great. It actually is really transferable on robots that look like this, right? And so, yeah, we created a toolkit of vision models and adaptive physics and control and planning, and it works on large, expensive, narrow-focused surgical platforms. And that's not really where we were wanting to go with that, right? Yeah, there's a lot of platforms out there, but these platforms are really expensive, and they're only found in basically large metropolitan centers who have a lot of money and can afford to have large surgical teams keep these machines alive to do surgery on one person at a time. But what about remote communities, right? And what about hospitals that cannot afford, various different kinds of narrow-focused surgical systems, each of them costing over $1 million each? So, how do we scale this? And when we thought about how do you scale a set of tools, we kind of looked to how humans scale their knowledge and skills. And one key aspect that seems very trivial, but is actually very key is that scaling and sharing of knowledge and skills in humans, and actually in all of nature, really relies on us all being of the same common physical form, right? We all have 2 hands, 5 fingers, head, eyes in the same places. And it makes it a lot easier for us to transfer skills. What about robots, right? And so if we think a little bit, further out, where could robots go with this? And, we didn't have to think too far out because almost within a few years, humanoid robots started appearing, both in popular media, but also in corporations that have a mission to kind of see a future of machine intelligence. And so, the Tesla bot may be the most famous example on the left-hand side, and a couple of other robots are shown here. But I'll tell you there's 300 humanoid robotics companies today. Okay, so that's maybe from like 10 companies a few years ago. And so this is a very quickly emerging physical platform. And the value proposition for this physical platform is huge because it's really the most general embodiment that you can have for our world, the world that we designed for ourselves, right? For our physical form. We can use a humanoid robot to be a surgeon. We can remotely control the robot as a human, one-to-one mapping. We could also place a robot side by side in an operating room with a human, so it can work autonomously with surgeons. And I will mention that traditionally, when you go into an operating room to do a surgery, there's actually 2 surgeons in the room. So one is the primary surgeon, and the other one is the surgeon assistant, or at least somebody that's like highly skilled at performing parts of the surgery. And that surgeon assistant is often holding something steady, sometimes for hours, right? So you can imagine that is quite a lot of skill and actually a lot of cost too for the surgery of somebody doing very little, work. And so we can think about using a robot to be in that kind of role. And same thing for nurse and technician, things like circulating nurses and scrub nurses. And so a year ago, actually a little over a year ago, we were seeing all these humanoid robots come out, and we're seeing them being put in factories, which I already mentioned already has great robots for. And we saw them doing kung fu and black flips. And I was like, where is this going? This is not helping humanity in any way that I can tell. And so we said, we have to set a vision for people that there is value in this technology to help, help us, especially in healthcare. And so this is Sergi. This is the first humanoid robot demonstrated in a hospital setting. We focus on hospitals and not just operating rooms because I think there's an enormous value in emergency medicine where you need quick, immediate access, and it's not always surgery. So things like ultrasound, very valuable for there to be a skilled individual to perform. Here are some examples of emergency medicine, breathing tube insertion. Interesting thing about bag mask ventilation is that robots can keep exact time, whereas humans cannot. So it's actually even better. And again, another example of suturing, but now with 5-fingered robot hands on a humanoid platform. All right, and so all of that was actually teleoperated because when you first start, the easiest way is to teleoperate a robot. One thing I didn't show is our most recent work in us moving a little closer to surgery. And this is an example of a humanoid, one of the humanoid robots we have in the lab, where we've tasked it to hold on to traditional surgical tools and complete one of the training exercises that they give to surgeons. And so it's one of my students that is operating the robot, but they're operating not a Da Vinci robot, not one of the traditional robots, but they're operating actually the humanoid robot in this case. And the value here is that, you know, a humanoid robot, it can basically eventually take care of itself. It can walk into the room, set itself up, take out instruments, get ready, you know, and if you were to really jump in and control it, it's all ready and it can clean itself up later. Whereas today's robots, giant systems, they wheeled in large carts, they take a long time to set up, really expensive, huge training teams. It ends up being a very labor-intensive process. Okay. But of course, we do want to get towards more autonomy. And so as we move towards more autonomy, one of the kind of immediate things we ran into, and this is, again, now we're talking about just in the last year of research, the immediate things we ran into is that robots, these robotic systems, we're asking them to do a lot with their hands, a lot of diverse instrument manipulation. And what we quickly realized is that these hands are not to the stage where they're exactly mimicking human hands yet. And so we had to do really weird tricks on how to grasp and utilize instruments. You'll see some of the hand positions and holding of things are really awkward and strange, and that's just what worked for us. And again, it's really because we have an incredible amount of dexterity in our hands, and to pack in the number of actuators and motors and drive technologies and sensors, especially sensors, into our hands, it's just not there. We have significant leaps in material science research that we have to still do to get anywhere close to the amount of sensing and control and actuation what we have in our hands. Doesn't mean that we can't still use the hands today, but we have to acknowledge that there's a huge gap, right? And so just as an example, the hands we use, the sensing pads are on the red. So if you contact anything outside of the red location, it will not know that it's touching anything, okay? So again, with the mindset that we could still do something very valuable, but we have to work around this idea of our hands are not like the humanoid hands, what do we do in this case? Well, we throw it back at this idea of reinforcement learning again, and we say, okay, in this simulator, here's an example of, you know, a surgical clamp, and I want you to play around with the surgical clamp in the simulator until you find a way that you can grasp it. And so it finds a way that it can grasp the surgical clamps that's slightly different than what humans would do, but it's at least a way that the robot is able to grasp effectively. And so here are some examples of it using different type of like tools that are a little bit harder to control. And these tools involve both grasping something rigidly in your hand, but also require some actuation of the fingers. So one might wonder, well, a lot of them are pretty close, so instead of throwing a whole bunch of computation at it and like having it play for a really long time to figure out how to learn to grasp objects and control them, could we give it like some demonstrations? You know, could we teach it, just give it a little warm start? And a lot of people in robotics are thinking about this, and what we realized again when we deal with surgery and surgical applications is that the sense of touch is really important, which can be very understandable, right? Like you want a good sense of touch as a surgeon because you want to be able to understand what you're interacting with and be delicate and careful with it. But if we looked at how do we basically have a user understand the robot's sense of touch so it can teach the robot how to do something, we actually had a very hard time finding anything that works where we could give a user the sense of a robot hand's touch, okay? And so these are all research prototypes, basically from other groups, but they all kind of only have the ability to pull back fingers. And what we realized is that nobody actually had the ability to give you actually directional force feedback on every finger, so that, you know, if you push a button, you'd be able to feel, oh, like there's a force pushing back in this direction against my finger. And that's really, really important actually in all of grasping and object manipulation. And so we built the robot, kind of this robotic hand, a glove, which we call the haptic glove, that gives you directional force feedback on every finger. And it really lets you feel what the robot's feeling now. Okay, and so this is very recent work from one of my students, you can see the one-to-one kind of mapping of the different fingers to the robot hand. And the idea is that with this setup, you can now feel around in the environment. Okay, and then I wanted to kind of highlight one final kind of idea, which is that, you know, we talked about humanoid robots in mostly surgery, maybe a little bit outside of surgery, but I think one thing that nobody really is looking at in the community right now in medical robotics is chronic wound care. And chronic wound care is a hugely important problem. It affects a lot of people, nearly 2% of the population. You know, wound that recurs constantly, can heal very slowly, and it can be a massive toll on patients, caregivers, and families. And if we can get a robot to learn how to change wounds and you know, change the dressings on the wounds, we can actually bring a lot more quality of life back to not only the patients but their caregivers too. And so we have to then basically teach a robot how to handle tape and dressings. And so this is an example, again, a very recent example of how we are teaching a multi-fingered humanoid robot to learn to interact with tape, peel it off, tape down things. And this is just a video example of it. We realized that these humanoid robotic hands don't have fingernails, so we had to give it an artificial fingernail there. But yeah, it's learning to kind of peel that tape off and then kind of pinch grip it and grab it. And this is all autonomous. Okay, so I want to end with, like, I think the future of robots in surgery is very promising and also at the same time very open-ended, right? I think we can talk about whether specialized robots are the future or ubiquitous humanoid platforms are going to be the future. I personally think it's going to be both, where specialized robots for particular procedures where there's great value in precision, and ubiquitous humanoid platforms for things that are not so concerned about, you know, precision. You know, things like, you know, you don't need to have millimeter accuracy on doing a physical scan or a physical evaluation, right? The question of teleoperated versus autonomous. We can always have a trained person operate a robot remotely, or we could teach these robots to be autonomous and perhaps scale to a much broader population. And then finally, the question, which I don't think anybody knows, is how far out is the future of this, or are we basically almost there? And I believe maybe in the next few years, we'll be starting to see a lot of key autonomy aspects of medical robotics and surgical robotics show up in our operating rooms to help our healthcare teams. Finally, none of this is possible with obviously an incredible amount of guidance from our clinical team of doctors, physicians, and practitioners, amazing students, postdocs, and staff that have helped build this engineering work up. Very proud of also many of those who have then gone on to their own faculty positions and grown this area of research. Thank you so much for your attention.